Good morning. It is Follow-Up Friday, July 16th. I'm Jessica Lovell. Welcome into the Morning Medical Update. Today we are talking all about COVID-19. Will you need a booster shot? What does that process look like? How is the Delta variant impacting our area? We've got those answers, and our panel today includes Dr. Stites, Steve Stites, he's our Chief Medical Officer, and Dr. Kevin Ault, OBGYN, and member of the CDC Advisory Committee on Immunization Practices. Welcome. And we also have Dr. Nathan Bahr joining us in for Dr. Hawkinson. He's an infectious disease specialist. Good morning to you. So glad you're with us. Let's go ahead and get started with you. Let's get to our COVID count and those numbers.
Yeah, so numbers are still pretty high here. 32 active infections, 12 of those in the ICU, 3 of the ICU patients requiring ventilators. There's also 10 additional patients that are not considered active infection, but still needing hospitalization. So that's a total of 42, still pretty high. And Hays has 4 active infections this morning. They had 2 yesterday, so that's double for them. So still seeing a lot of cases, a lot of people needing hospitalization, and some really sick people too.
All right, Dr. Bahr, thanks for the update. We don't like the update, do we? You said we're in trouble.
No, we are in trouble, Kansas City. If you look at the kansascity.com, they've got that nice curve they show you every day. We're on the exponential size, the rise. It doesn't look like as high as it did, obviously, in November, but it's high. And these are the highest numbers we've had at the health system since February the 19th. So clearly on the rise. Don't like it. I think trouble's here.
Dr. Ault, your thoughts on those numbers? You said you're seeing more pregnant women lately.
So there's been a lot of data about pregnant women, pregnancy outcomes. Most of the pregnancy outcomes that you can think of, like stillbirth and preterm delivery and hospitalization, are worse with COVID during pregnancy, and we have a lot more data. It's been a couple of months since I've been on. We have a lot more data about the safety of the vaccine in pregnancy as well as the outcomes in pregnancy. So yes, the news is bad in my area as well.
All right.
Just to say, I think we've got a tough combination right now of what we're seeing, because it's the unvaccinated people. For the most part, we do have some vaccinated patients in-house, like we have 6 of them right now. It's 16% of our patient population, but they're all very severely chronically ill, people who you would expect and maybe not have a good immune response. But we have a lot of young people who are unvaccinated now. The story has turned, and I think it's the rise of the Delta virus, combined with the removal of mask mandates and social distancing and people gathering together, going back to camps, trying to do everything like it's a normal life, bringing COVID in. And you can see, you watch the numbers, they're just crawling up in every county by county, right up from the Springfield area and from the northern part of the north central part of Missouri. They're kind of converging onto Kansas City. I think we're going to find it. We'll have our CMO call today. I already know the numbers are up everywhere.
All right. Okay, so I want to just get to some reporter questions. I know we have a lot to get to today. Any reporters on the line?
Hi, guys. It's Taylor from Channel 41. Good morning.
Hey, Taylor.
I wanted to ask about, is there anything, I know it's probably in the earliest parts of data for this question, but are we learning anything about how, what we've seen so far about how those who are vaccinated are reacting once they test positive? I'm seeing a few stories here and there pop up, some celebrities who say they're, fully vaccinated but still testing positive and that kind of thing, encouraging people to vaccinate. Is there anything that we're learning so far about how COVID reacts to people who are fully vaccinated once they test positive?
Clearly, people who are vaccinated are protected from critical illness and death and hospitalizations, but you can still test positive, Nate, and we know that that's the case, and they can still spread disease at a diminished rate, but they can still spread it.
Yep, and those are, I think, the most important points. The national data is really clear on this, and I think this is what we're seeing very closely as well. 99+% of hospitalizations and deaths are in people that are unvaccinated. Most of the hospitalizations that we're seeing, as you mentioned, Dr. Stites, are if you're fully vaccinated and you're still hospitalized, most of those people have, some underlying condition where we wouldn't expect the immunization to work quite as well. So yeah, if you're fully vaccinated, you can still definitely be infected, but you're much less likely to get very ill from it. And although you're not as likely to spread, you're not going to have as much virus to spread. You can still spread this, and so it's important. If you have a sniffle, get tested, because you could still spread this to somebody.
So I had a family reunion I was supposed to have last night, and with my side of the family, they live in Tulsa. One of the daughters was coming up. She was coming from D.C. Her son was sick, and so had to get him checked But the problem was he had croup, para-influenza, which causes croup, not COVID. But you had to be checked, right? You had to be checked to be sure. Because, Kevin, lots of problems right now, and I'm sure you guys are talking about it nationally on the advisory committee.
Yes, I mean, we've talked about the Delta virus. We've talked about other variants. We've talked about boosters and all the things that we want to talk today. The CDC does maintain a website, though, of breakthrough infections. I haven't looked at it for about a week, and let's see if I can remember this off the top of my head. 157 million fully vaccinated Americans and 4,700 or so breakthrough infections that they've tracked. About 20% of those people were not symptomatic and probably just found through screening. So there's very good protection against hospitalization. Also, since we've had our last ACIP meeting, there's been some coverage about the situation in Israel, and it shows, as other people have been saying here in the group, that we have good protection against the severe outcomes. It's somewhat similar to influenza. You know, we have some people can still get sick from influenza and maybe miss a few days of work, but they don't end up in the hospital. I mean, that's what we see with some of these vulnerable groups with influenza. So,
Taylor, follow-up question. Any other reporters?
I do have a follow-up. It's okay. I just wanted to ask, and you kind of touched on it there a little bit about, but more and more people are returning to work and being around each other, and mask mandates being gone if most people are vaccinated, that kind of thing. How likely is it, or I guess the best way to ask is it more or less likely that I could have COVID and not know it because I'm fully vaccinated, not really exhibit symptoms or anything like that? I mean, does that make me more or less likely to show symptoms if I test positive if I'm vaccinated and don't really know?
I'm going to repeat this and say it back. I think it's more likely if you are vaccinated that you won't know that you had COVID because it tends to be more asymptomatic. But you still may have some mild symptoms. And the answer to that is get tested, right, guys?
Yeah. Yeah, the symptoms may be so mild that you kind of brush them off, right? You wake up in the morning with a sniffle and, I don't know, by the next day it feels okay and you kind of don't pay attention to it. It could be as simple as that.
And the problem is if you're around unvaccinated folks and you have COVID, there you go. The other point to remember is if you have any kind of a sniffle, put your mask on because what happens is you prevent being spread. We know that the rules of infection control, they keep you safe no matter where you go, Jess.
That's what you've said from the beginning. I do have a question from Donna over at KMBC. She said this is her long-winded question. It's actually a really, really good question, so I am going to read it. The monthly positivity rate in Kansas has gone from 2.8% just 2 weeks ago to 7.4%. In Missouri, it was 8% at the start of July. Now it's more than 13%. She says, I remember when we were trying to get those numbers down to 10%, and now this sharp reversal. Are unvaccinated people the X factor or common denominator here, along with the Delta variant, or is there more at play? And what can we do? Do businesses need to start putting mask mandates in like LA did?
Right. It's what we said at the very beginning. Unvaccinated people, a highly contagious, more contagious variant, and the loss of all the public health mandates, right? You've removed all the things. People are back in public together. They don't have masks on. They're doing all the stuff indoors that they wanted to do for a long time. I think that last piece, I think that's actually the secret. Because we had unvaccinated people, more of them, back when we were down to 2 inpatients. Now, we didn't have as much Delta virus, and Delta's highly spreadable, but we also had the mask mandates in place. So I think, we're going to come to a reckoning again at some point. And I think the reckoning is going to be, for those who are unvaccinated, are we all going to have to put masks back on? And I think that's the question we're going to be faced with. And I think that question is going to come up on us in the next week, 1 to 2 weeks, because at some point you're going to look at this and you're going to say, we're in trouble. And we don't like to raise a false alarm bell, but the reality is the numbers are rising exponentially in Kansas City. They're out of hospital beds in Springfield. They're building an alternative care area. I don't think they've gone to, unless I'm wrong, I don't think they've gone back to mask mandates in Springfield or southwestern Missouri yet. I'm just going to tell you, if we run out of hospital beds in Kansas City, the problem we're going to run into is that people have a heart attack and stroke and break their leg or in a car accident. Where are they going to go get care? Right? Where are you going to go get care? And at that point, you're going to have to weigh the public good, which is exactly the discussion we had last November.
Well, it seems like these are the same things they were seeing when we went into the mask mandate in the first place. So what's it going to take, do you think?
Right, exactly. I don't think anybody's ready to do that yet. I don't think there's the political nor the social willpower yet to do it. But I think at some point we could get faced with that if we end up like Springfield. And I'm really concerned about, if again, just look at the rapid exponential rise in COVID.
I would say personally, I've been wearing a mask. I haven't stopped because I've just thought it's not a big deal for me, and I would like, on the off chance I get infected and I'm asymptomatic, I'm just going to wear it so I don't spread it to anybody. That's been my opinion on it. I think if you want to do some social good right now, and you're vaccinated or not, a big way to do it would be wear a mask.
Wear a mask. So don't you think the calculus is this? And I want to, you know a lot much about vaccines than me at this table, Dr. Ault. You know, in the past, we didn't have many people vaccinated, but we had mask mandates. Now we have people vaccinated, about half of our metropolitan area, but all the mask mandates and distancing measures are gone. Which is going to be the bigger variable between those two? This circumstance or this circumstance? And my problem is, I don't think we know, but I'm worried about this circumstance.
Well, we always have vulnerable people who don't respond to vaccines. That's why we rely on herd immunity. You know, there are going to be people with cancer, immune suppression, kidney transplants, what have you, that don't mount a good response to any vaccine. And so they're dependent on you and me and other hospital employees and their family on getting vaccinated so they don't get infected. And so sometimes you hear that called hiding in the herd. You know, we're not close to that number yet. And that number becomes more elusive and higher vaccine coverage needed because of the transmission of the Delta variant, as you said, since it's more contagious.
All right, so we are going to get to your community questions here in just a moment. But Dr. Ault, I have to ask you if you could give us a little bit of a tutorial about the committee you sit on and the relationship between the ACIP committee, the FDA, and the CDC. Kind of tell us about the flow of the decision making so people understand how that works.
So I think of the FDA as being thumbs up and thumbs down. They have a committee too called VRBPAC. It's a little bit larger than the ACIP committee that I'm on. Their hearings are public. Their documents are public. You can find all this, and similar to ACIP, everything is public. But you know, they say it's good to go for the EUA or it's not good to go. And so, and then the ACIP committee gets out into the weeds. You know, who should get the vaccine first? Can you give the vaccine at the same time as flu vaccine, for example? What are we going to do about side effects we discovered after we finish the clinical trial? So we do all the clinical kind of macro management of the vaccine recommendations after the thumb up or thumb down.
Okay, thank you for that. Okay, thanks for clearing that up. Okay, so we're going to get to those community questions. I have several left over from this week. We had a lot of good ones, and Jill, I know some good ones are coming in this morning from the community, so we'll get back with you here in just a moment. But the first question today, why can't immunocompromised people here in the States get a Pfizer booster shot like they're getting in Israel? This person says, I'm tired of masking and isolating to stay safe.
Yeah, you know, that's a great question. We're going to ask Dr. Ault that question since he's on the hot seat for that one.
So I'm on the American committee, so I should point out. And I've been to Israel before, and it's a very compact, small nation with a single healthcare entity. I think there are 9 million people in Israel. Most of what I've gotten is from press reports. I haven't talked to any of my colleagues in Israel. I mean, they really had it down to just a trickle of cases. They had in a nation of 9 million last week, they had about a third as many severe COVID cases as they had in Springfield, Missouri. So I think I'm trying to read their mind. I'm thinking that they're thinking we're going to go all out to get this under control, and so we're going to try something, you know, to get people vaccinated. The situation in the United States would be, why are we talking about a third dose when we have half the country that's gotten 0 doses? You know, I mean, that's an entirely different set of circumstances. And most of their cases are due to the Delta variant. And so, you know, so I'm trying to read their mind and project what I might be thinking if I was a health official in Israel. And so I'm guessing that's what they're thinking.
And I think we're seeing some of that data. If you look at the organ transplant data, the percent of effectiveness after 1 shot is like 15 or so, and after 2 shots, it's like 40. If you get a third vaccination, then the effectiveness is about 68%. So that, you know, starting to really get better numbers. But it took the 3rd shot and maybe a 4th shot. And then when you look at what Pfizer is saying is, gosh, we think we've identified certain populations who may need this booster shot. And you think, well, I just wonder if we're not all saying the same thing. Israel's saying, it's not everybody's going to get that 3rd shot. It's a select population. And again, it's the severely chronically ill patients. It's the ones who are in our hospital who've been vaccinated are still getting COVID and getting sicker. And remember, this is how you have to look at the world, guys. It's not an either or question. So if you get COVID-19, you may not get as ill once you've been vaccinated and you're severely immunocompromised, you don't have quite the same immune response. But if you have a very narrow window that you have to walk every single day because your heart failure is tightly controlled, let's say you have heart failure, kidney disease, you're on dialysis, man, your fluid shifts are just a little bit and boom, you could be in the hospital. It doesn't take a lot to tip you over. You don't have to have full-blown COVID, but you can get COVID just as you can get influenza, or frankly, you could get a cold and you could get tipped over and come into the hospital. That's what we're seeing with those patients who are vaccinated and coming in. So if you've been vaccinated, but you're severely chronically ill and you know who you are because you have to walk that narrow window, you should still wear a mask. And in my opinion, you should still wear a mask and you should still be practicing social distancing in order to stay safe. And for the rest of us, you know what we're doing is all the unvaccinated people are now relying on the vaccinated people to be the roadblock that allows society to stay open. They're the roadblock, the Delta. I think about the social calculus for just a minute. Those who are vaccinated are now being the roadblock and being the buffer that allows the unvaccinated to stay safe even when we're having a rise in Delta virus. The problem is you're not safe because we don't have enough, to your point, we don't have enough people vaccinated yet. You just got to get vaccinated, folks. This is not dangerous, it's not new, and it is incredibly safe. We've given over 1 billion doses worldwide.
I think if you want a really deep dive, we talked about this at the June 23rd ACIP meeting, and those meetings are recorded and put on YouTube. So if you want to hear us talk about this for 90 minutes, you can do a deep dive, in your spare time on YouTube.
I bet you're pretty interested. That'd be pretty cool.
There are 100 people in those meetings, but we really get to hear from some experts. So it's good information if you really want to dig into it.
So if you want to nerd out like Nate Bahr,
yes.
I bet he would do that.
Nice. Spend your Friday night doing that, yes. So, yeah.
All right. Well, Dr. Bahr, okay, so this next question, I think I'm going to start with you. I got the J&J vaccine in March. Can I get an mRNA shot at any time? Should I do so to better protect myself?
I think this is sort of a question where we need more data. There is data out there on the AstraZeneca vaccine, which is not approved in the U.S., but some of the trials were done here, and it's sort of, I don't know, I guess a bit of a relative maybe would be the way to say it of the J&J vaccine. And so there is some data there in terms of both being fairly safe and providing perhaps some benefit, but it's as far as I'm aware, there's not really data with the J&J vaccine followed by an mRNA booster, and that would be what I would want to see before I would be recommending it.
So can I just ask you guys a quick question, because the New England Journal of Medicine this week published data showing that in response to if you've had the AstraZeneca vaccine and your next shot is AstraZeneca versus an mRNA vaccine, you do better with the mRNA vaccine in terms of immunogenicity as far as antibody titers. Does that make you think, gosh, we should be giving people mRNA boosters, or what do you think?
I mean, that's a great research question, but as you said, I don't know that we're there as far as clinical applications. And again, on June 23rd, we talked about some of these things. And so the data is just not quite there yet, but it's interesting to talk about. So.
Okay, next question. What are the financial costs to people who refuse to get vaccinated? Are taxpayers footing the bill for anti and hesitant vaxxers who end up in the hospital or can't work? What are your thoughts?
Okay, so medical economics question. I saw this question last night. I was trying to figure out the answer to it. So this is a hard one to answer because the cost of COVID hospitalization is much higher than the cost of a routine hospitalization, and in fact, about 1.5 to 2 for medical illness. And so it is more expensive. So the average hospitalization for a standard medical patient is $15,000 to $20,000. COVID's more than that, $30,000 to $40,000 range, just as an example, although those aren't far off numbers. The question I would ask is, in general in society, if you are not taking care of yourself, do those who have taken care of yourself end up having to bear the cost? And the answer to that is yes, because we have to find a way to keep the doors open to take care of people. And so the way that happens is that those who are commercially insured pay higher rates because hospitals have to have some way of getting enough money to pay for the cost of taking care of people who are uninsured. And to the point that oftentimes those who are refusing to get vaccinated have a higher incidence of not having good insurance or not having any insurance, yeah, that can be true. And so, yeah, we all have to pay more money. We all may face social isolation again, and we may all face more mask mandates because people won't get vaccinated. Those are all true statements, right? They are true statements because when you have a population who is fully vaccinated, you're not going to have a runaway with the Delta virus.
Well, one of the things we've talked about quite a bit lately at ACIP is that vaccinating children, because we did go down to age 12 with recommendations recently, you know, that's the group that could be very costly. We don't know what the outcome of long-haul COVID is with that population, but, you know, if somebody gets a disability when they're 12, they're going to end up on Medicare or Medicaid for the rest of their natural life and be very expensive. So, yes, it's going to end up costing us for that reason and for this reason as well. So,
and long haul syndrome, guys, I'm just going to say it to you. Can I cuss on the air, Jill? I can't, can I? It sucks, people.
No.
Okay, it's terrible.
Please no.
It's darn bad.
But after
it's
you
darn
can,
bad.
I promise.
Okay.
You can let her rip. Okay, so Dr. Bahr, does blood type have anything to do with how resistant a person is to COVID-19? Is this an urban myth, or is this being studied?
It's definitely being studied. There is a lot of reports out there about this. And I think the trick that I've found is a lot of these reports sort of contradict each other a little bit. So you'll see one study say, well, you know, ABO or AB blood type looks worse, but all the other may be better. And then, you know, you'll see another study that says something very different. So this is definitely a point of interest, but I'm not sure I'm very confident to say that one particular blood type is protected well or not.
Anything else to add, Dr. Ault?
I mean, I think it's an interesting research question. It probably correlates with a lot of other HLA types and that type of thing. But yeah, once you get out of a population and try to go to another population, a lot of times it breaks down. So as you said.
Is the Delta variant more deadly if it is also more contagious? Do you still have deaths from COVID-19 at the health system? It's a two-part question.
I think our last death was July the 8th.
Yeah, we still have deaths. Yeah, it's sad, and we do. Is the Delta variant itself more contagious? Absolutely. Is the Delta variant, you know, causing more severe disease? That I don't think we have good evidence that it does. But you know, when it's more contagious, it's going to get to more people, and if it's causing just as bad disease, we're gonna see deaths continue, severe disease continue, all that sort of thing. So, you know, the big scary thing with Delta variant is that it is just a lot easier to transmit.
And just to say, the New York Times free and open to the public this part about COVID, they showed the graph in England where the Delta virus was originally overwhelmed, but there were more deaths, but it was just because there were proportionally more people getting the virus.
Right.
It didn't look like the risk of death if you have the virus is not higher with this than the original strain. The risk of death is higher to the population because it's more transmissible.
Yeah, no, I agree. I think that's what the data shows.
Okay, so next question. A lot of parents wanting to know this one, me included. When will a vaccine for children under the age of 12 happen? Where are we in the process? What are the next steps? Dr. Ault?
Well, we've had our colleagues from Children's on this morning update several times. Dr. Pahud is my friend that works over there, and she's in charge of several of the trials. I think we're probably still a few months away. Strangely enough, this little uptick may accelerate that time because there'll be more kids getting exposed to COVID. And so if you're doing a blinded prospective trial, trying to figure out there's more community exposure. And so, I mean, I think we're hoping sometime this fall, but I you know, that's speculation on my part.
Do we know if we've had any hospitalized patients who had COVID-19 before and then now they have it again?
Yeah, I don't know the answer to that. Do you guys?
We don't right at the moment, but I'm not sure we haven't had.
We have had. There have been a few people who have had COVID and then get hospitalized and then have COVID again, get hospitalized a second time. But to be clear, one of the challenges we face on that is to know if they really ever eliminated COVID altogether the first time, because a lot of those folks tend to be the more severely chronically ill patients. So a little bit of it's a nuanced question. It's a great question. It's a nuanced question. The answer is a little bit harder to come by still.
All right, so the Zoe COVID tracker from the UK shows the top 5 symptoms from the Delta variant as headache, runny nose, sneezing, sore throat, loss of smell. That differs from the top Alpha variant symptoms of loss of smell, shortness of breath, and fever. Do symptoms for Delta and Alpha variants present the same in the U.S.?
Yeah, these are pretty subtle differences because those may be the top 5, but if you go down to the top 10 on both sides, the lists match. And so I just frankly would not put a lot of stock in that. And so is the Delta variant presenting a little differently? Yeah, it probably is. Is it within the realm that they're very more similar than they are different between the Alpha and the Delta? Yes. And if you get any sniffle or any sick, or if you get a flu or a diarrhea, you still got to get tested. I mean, you just go get tested.
All right, the CDC and the WHO monitor variants around the globe to determine the most dangerous. The U.S. classifies the variants as a variant of interest, a variant of concern, and a variant of high consequence. Why is Delta only a variant of concern? What are the differences in classifications?
I think I know.
I think I know too, but go ahead.
You can amplify what I said. The reason that it's not yet of high consequence is that it appears the vaccines still work. It also appears that the monoclonal antibodies may or may not be affected as far as therapeutics. I probably should punt to somebody else for that particular question. But there are data that you still can neutralize the virus in a test tube with sera, with blood from vaccinated people. And there's clinical data, and I think we talked about that from Israel. There's also some American studies that vaccinated people are still protected. The highest category there is when we were failing on multiple fronts. If therapeutics don't work or diagnostics don't work, and our vaccines don't work. Unfortunately, we're not in that boat yet. There's no virus variant that's in that category yet.
And I would just say if the variant was also more deadly.
Right.
Well,
because of all those things.
Yep, exactly. But the other point about those monoclonal antibodies, again, New England Journal yesterday came out and they looked at really a large population of the Delta variant, that the new combination therapy of, I'm going to mess this up, bamlanivimab and erasintamab or something such thing, worked very well for patients to prevent hospitalization and death.
Yeah, we've used a lot of monoclonal antibody. In fact, our use has been going higher and higher in recent weeks as these cases have been getting higher. We're using the Regeneron antibody. There is not a combination with bamlanivimab as part of it that's available right now. Everything's been pulled because of concern with activity against various variants. But we're using it, and the Regeneron we're using, and it really does seem to be working quite well.
Yeah, and I think what's going to happen is now that Bamlam will be combined with this other one, and we'll really have 2 choices out in the market in the near future. And then we can still say Bamlam, which, let's just be careful, that's cool.
You were mourning, weren't you?
That's cool to say Bamlam.
Okay, early in the pandemic, you advised family gatherings to avoid family-style eating. Is this still a concern with the newer Delta variant that spreads more easily?
I think it comes down to, are you vaccinated? If everybody in your family is vaccinated and you think you can all be safe and you don't worry about taking it home to anybody who's not sick, you can probably make some choices around that. But if people aren't vaccinated, the chances of them somehow picking up the Delta virus, Nate, they're high.
Yeah, you're right. I mean, you're right, because the big choice is vaccinated or not, right? And then when you're down to, well, how should we eat? What way is best? You're talking about risk that is really dropped just by making that vaccination choice. So the first choice is get vaccinated, and then your risk is going to be, much less, whether you're, eating in close quarters, whether you're, eating buffet style versus a boxed lunch or something like that. That's the best choice you can make. But yeah, I mean, there could be some risk with some of these things, of course, but number one, get vaccinated. You're going to feel a lot better.
All right, Jill, I want to bring you in. Do we have some community questions we have time for today?
Oh, of course we do, and they are wonderful questions. You've answered a lot of them, but we do have a couple. Here's one for Dr. Ault. Susan and Karen kind of want to know the same thing about the safety of the vaccine for themselves, for people planning to have a family, for their young daughters. Karen in particular said that when she got the J&J, her menstrual cycle changed, and so for several months, and so she's worried about giving it to her daughter. What would you say?
So there has been some data, and there's biologically plausible mechanisms for changing your menstrual cycle from these vaccines, because the lining of the uterus is where the blood comes from, and there's receptors there for inflammatory markers, and so that makes some sense. So to me, and so However, when you look at the interruption of menstrual cycles due to stress and other things that are independent of vaccines, those things are through the roof for the past year in the United States. So it's probably biologically plausible, but I don't know that it's not a sign of the times that we're under, and I don't think it has any long-term consequences. So the other thing is, we were vaccinating back in the beginning from higher age range down. So once we got to the 50s and 40s, that's a group of women that are going to have a regular menses anyway, and now we're vaccinating 12-year-olds, so that's another group that would have a regular menses. So those two extremes of menstrual, life are teens and women in their 40s and 50s. So there's active research. There's actually online surveys you can sign up for. So I'd certainly encourage you to be part of that research if you're a woman and that's a concern and you're willing to volunteer for a study, which is actually a pretty easy study to be in because it's mostly just a survey.
Okay, Dale writes that he and his wife are 72 years old. They've got a beautiful new 4-month-old baby that they want to go and see. However, Grandma got exposed to a known case of COVID. So everybody's vaccinated, but they're just wondering, should we wait to go see our little 4-month-old?
I would just wait. I would just wait. I mean, I get this question. I totally understand this question, right? I have a almost 2-year-old now, and a 4-year-old, and my almost 2-year-old saw his grandparents when he was a newborn, and then not for a year plus. So I completely understand the parents wanting the grandparents to get together with the kid. I completely get that. But to me, I would say if there's just been a recent known case, let's just wait until we're past that window and make sure everything's okay. There's no reason to risk that exposure.
Well, I'd say the same thing. If this is the Dale Rice, who's 72, who I work out with sometimes, Dale, I hope you're doing well.
All right, Isaac wants to know, do you think events will be shut down and we'll go back to where we were? He's concerned about that. What are your thoughts?
I'm concerned about that too, and I think the reality is that it's all going to depend upon our social level of responsibility and what happens in the numbers. And we've said before, we'll know far more in 2 weeks than we know right now, and that's the truth again today. I think the challenge for us is this. People aren't vaccinated. Delta virus is out there. It's the 95 to 96% of all the types of coronavirus people are getting right now are the Delta variant. It's more transmissible, and folks are not following the same social rules as about isolation. So the question for us here in the metropolitan area, because we are more vaccinated than the rural counties surrounding us, by and large, is that going to be enough of a defense mechanism to prevent higher case numbers when we don't have social isolation and masking in place, or physical distancing and masking in place? I don't know right now, but I am concerned because we're seeing such a rapid rise and it's going to continue to spread. That's going to put a lot more pressure on healthcare. And just to say, yesterday we started the day with 801 patients. All our beds are full. So if we get to the numbers we had in November, when we had 250 COVID patients, either acute or recovering, where will those patients go? And at that point, there were 600 patients, there were 700 patients throughout all of the major health systems in Kansas City with COVID. Where were those patients going to go when all the beds are full? That's the dilemma we're going to face, and I think that's what's going to force us. If we hit that point, that's what's going to force us more into the same things we had to deal with last fall. And just to say, in Springfield, they've appealed to the state to bring in an alternative care location because they don't have enough beds. And the state can't absorb their patients, and that's the other problem. They're having a hard time placing those patients who are COVID-19 positive and are sick because there aren't enough beds in the state. That's going to be, guys, that's the fulcrum. That's going to be the decision tree, and I am very nervous, and I would not be surprised to see us have to reinstitute physical distancing and social measures like this.
I'll just add, if I can, our vaccine numbers, they are higher than many rural areas. They're not high enough.
They're not high enough.
We still have a lot of people at risk in our area.
And we have a bigger population who are more concentrated, doing more stuff together, which is going to put them more at risk.
Yep.
So my gut feeling is, yeah, we're going to head up back there.
Okay. Cindy.
Okay, so can I just say, that graph that you can see right now, that's the hot spots, and I don't know if we can get to the risk graph, but what you'll see is this is encroaching on Kansas City as you move up and up through the state, and there it is. Okay, that's the risk graph. This is out of the New York Times. You can see this for yourself, but see that deep purple? Those are the counties that are at the most at risk. See that deep purple right up here at the Kansas-Missouri border right around our area? Those are the counties, and this, a few weeks ago, this is just a few counties in southern Missouri. Now it's coming right up to our gates, and if you look at northwestern Missouri, it's coming down towards us. So, it's like that big pincher movement, and it's coming at us, and it's going in from Kansas as well. It's coming in from the eastern side of Missouri toward us. So it's coming to us, folks. We have to take responsibility, and the only way to do that is to protect each other. The only way to protect each other is vaccinate, and you start getting protection. Almost as soon as you get vaccinated, even with one shot, you can start getting protected.
We can blunt the curve, just like we did before.
We can bend that darn curve. You bet we can.
All right. Cindy and Annie want to know about testing for COVID. What test, and is it different for the Delta variant?
Same tests. It's the same tests we've had available. There's PCR testing, and then there's the rapid antigen testing. They're both still available. We still see that these work just fine for the Delta variant. That's part of the whole variant of concern rubric as well, by the way. If it starts messing with our diagnostic tests, that's part of the trouble there, and we haven't seen that. So it's the same tests. You can get them all the same places. It's really the same way to go with that.
Okay, Kylie has a question for Dr. Bahr. She says, my brother and I got into a deep discussion. Families are doing this all over. Kylie, you're not alone.
Kylie, you're making me nervous.
Yeah. Yeah, it gets good. She says, my family's vaccinated, his is not. The reason that he gives is because he believes that the vaccine does not clear the body, meaning the components of the vaccine stay in our bodies forever. And we do not know if there's any future side effects because of this. What would you say to Kylie's brother?
Well, I see a hand raised from a vaccine expert, Dr. Ault, so perhaps I will let him chime in.
So the 3 vaccines that are under emergency use authorization right now don't really have a mechanism to do that. And so the Pfizer and Moderna vaccine are made out of RNA, your body and lipid. And your body has plenty of ways to break down RNA and lipids. So maybe a matter of days or hours. We don't really find vaccine side effects past about 6 or 8 weeks for any vaccine that we've developed. And so the Johnson & Johnson vaccine is a virus vector that doesn't replicate. So again, there's no mechanism for it to persist. So I don't think any of that is accurate. It's going to be cleared by your natural mechanisms that you have. So.
Yeah, I've heard the analogy with the mRNA vaccines of a Snapchat message. So if you're somebody who uses Snapchat, that might work for you. If you're not, never mind. But essentially, it's a message that gets sent to your body. Your body uses it, it goes away. It's gone.
So the parts of like the polyethylene glycol, that's eliminated too. It's broken down and gone. And I suspect that's what people are talking about with the messenger RNA vaccines. The polyethylene glycol hangs around. No, it doesn't.
Nope.
But there are so many things that have polyethylene glycol in them, that ice cream and all, a bunch of things that you are exposed to every day.
You're absolutely right.
So
Miralax.
Yeah, well, there are lots of things.
Some things are better than others. Like
I wasn't going to go that route. So.
And Dr. Bahr, I totally get your Snapchat reference. I'm with you. I got
it too. It does,
Are you sure?
There.
I thought I had to explain it to you.
Later.
Okay, let's take a couple of more real quick questions. Please help Michelle. I can just, she's got 2 or 3 questions on here, but I think at the bottom line, and I feel the anxiety that she is feeling. We've been here before when we had higher infection. Michelle says, why does it matter if I get vaccinated? The risk of catching it is the same! !
Your risk of catching it,
It's
you can
not
catch
the same.
You can
But
catch
the risk is not the same. The risk goes down dramatically.
Yeah, your risk is not the same. But here's, even past that, okay, here's the more important point. Your risk of dying, your risk of being in the hospital, way down. And your risk of hurting somebody else if you get infected goes way down. I think that is a really big deal.
It's we the people. It is not the same. And the basic part of that question is not true. your risk of getting it goes down, and to your point, your risk of hospitalization, death goes down dramatically, unless you've got a lot of chronically comorbid conditions, in which case you're still better, but still wear your mask.
Lindell wants to know, do we know how much previous infection protects against the Delta variant?
I think the data says not much. So again, we got updated on this on the 23rd, and most of what I'm getting is from social media. The NIH director has actually kind of been on a tear on his Twitter account about tweeting about this, but basically not as much as we would like is what it boils down to. The vaccines are probably better for a broader immune response. And there are a couple of examples of the immune response to vaccine being better. Human papillomavirus is a vaccine that I've worked on quite a bit, and that's an excellent example. That's and tetanus is another example. So there are several vaccines that work that way.
2 more questions. Jennifer writes, regeneration. Am I saying that right? Regeneron?
Regeneron.
Yeah. Is it a less effective treatment in people who have comorbidities like obesity?
Was really targeted for people like that. So, the studies that have been done on this product, they really tried to target high-risk group people. And, all the outpatient studies, that are working with the Regeneron product, we're seeing, rates from 6-7% hospitalization down to 2-3-1, that range. And our data is right in line with that. So if I was a person who had that risk factor or a number of other risk factors and got infected, this would be something I would be looking into myself.
I would just say that the sicker you are, the sicker you are.
Yeah.
Right? That's true about everything you do in life. The more chronic disease you have, the sicker you are. The more sicker you are, the sicker you are. Brilliant thoughts. Took a medical doctor to say that. But the reality is that that's why we have therapies out here to help protect you.
Yeah.
And so, monoclonal antibodies, they still protect you if you're sicker. That's where we want you to get them. If you're otherwise healthy, you probably aren't going to need them. In fact, that's not even an indication right now. If you don't have some baseline illness, Nate, you're probably not going to get monoclonal antibody therapy.
Right. Yep. We have our criteria for those.
Okay, Bridget gets the last question. She wants to know that after FDA approves the Pfizer vaccine, will physicians be able to use it off-label, in particular to give a third booster to people who have chronic illness and immunocompromised?
Oh, that's a great question, Dr. Ault.
Well, people can certainly use vaccines and drugs off-label. I mean, I would just prefer to wait for the data, because Pfizer has some data that they're supposed to present to ACIP, and so does Moderna. So, stay tuned. We usually have 3 meetings a year for ACIP. We've had more meetings in the past 6 months than we usually have in 5 years. So we're out there having hearings and posting them on YouTube and live streaming them, and I can certainly come back and be on the show after our next meeting. So, but there's going to be data to answer those questions, in a well-done study.
So can I ask a question of Dr. Ault?
You can ask a question.
When are you going to approve the DART drug?
Well, I just said earlier the FDA is the one that gives it up or down, so I'm not. I don't.
So we can't make you have personal responsibility.
Cannot make me have personal responsibility. One of the things I used to live in Atlanta. I've had colleagues that I've known for decades that work at the CDC. I mean, the problem with the FDA and the CDC right now is there's so much work to do. They have to prioritize it, and so if going from a BLA is what the formal approval for a vaccine is called. If going from EUA to BLA is going to take, a month of somebody's time, some supervisor at the FDA is having to say, are we going to take our people off of something else to do that? And so it's kind of similar to the hospital beds. There aren't enough hospital beds, and there aren't enough, FDA and CDC experts. Some of the people I know that work on hepatitis are working on cruise ships now, for example. So, they spent their whole career working on hepatitis. Now they've been pulled off to talk about cruise ship safety. So, and they can certainly do that work. That's in their skill skill set, but we're not going to make much progress against hepatitis while there's an emergency going on.
So, and my only other thing is, folks, A, you know you can get the drug now. You know it's safe. We've been talking about how safe it is anyway. But if you really felt like there's somebody who you could give a third dose of vaccine to, you can give a third dose vaccine now. I mean, you can give it. It's just we don't have the data yet to support it, and so people have been reluctant to do that. And plus, one thing we haven't said today is the only way we're going to be safe is once we get the world vaccinated. It's not enough to get everybody in America vaccinated. So if you start using a lot of vaccine here, are we shorting it somewhere else? And I think that's just that's more of a theoretical or moral question, but we have to get the world vaccinated. Until we do, we're all not safe from the variants.
Absolutely. I'd just chime in there. I work in Uganda real closely, research collaboration for a decade plus. They need vaccine desperately. And they're not alone. This is a situation in many countries around the world. So you're absolutely right. This is a global problem, and this isn't. We can hunker down a bit, then that's great. We can get all the vaccines we need to. That's all really good too. But we have to address this globally.
Well, I mean, the director of the World Health Organization said exactly what you said just a week ago. Is that rather than talk about 2 or 3 doses, let's talk about vaccinating the whole planet.
Right, great insight and great questions today, Jill. Thanks for getting those, and we'll write those down and we'll get to those as soon as we can. Okay, so it's time for final thoughts, but I'm going to go first if you don't mind.
Please.
Okay, so we're going to start today. I wanted to bring everyone kind of an update on a special young man who got his COVID vaccine for his birthday. So you remember Max? We met him last month. Max lives in Jefferson City and recently celebrated his 12th birthday by getting his first COVID vaccine. So we found out that Max got his second dose this week, and he's doing great. Max's parents are thrilled. Their entire family received their vaccines, and now they're going to feel safe and comfortable attending and traveling his soccer league games. So kind of my final thought is be like Max.
I like it. Way to go, Max.
All right, Dr. Bahr, let's go to you.
Well, I'm very jealous of Max and his family. That's awesome.
Awesome.
I think I would just say let's drive home some of the same points. So if you haven't been vaccinated yet, please do it for yourself. Do it for your community. You could be saving people's lives that you've never met or somebody that you love dearly.
Dr. Ault?
Well, I mean, I think there's going to be new information coming out that's going to answer a lot of these questions in the next few months. But in the meantime, I think I would agree with both of you. I have a Saturday morning routine of going to the Overland Park Farmers Market, and so you might see me wearing my mask there. I've been vaccinated, but for some of the reasons you mentioned earlier, I'm in the habit of doing it, and I don't want to infect my favorite vendors or other markets. So yeah, so I would think that it's not a big ask to do either of those things.
Yeah, good message. And you'll be back. I know you're kind of busy these days, but you'll be back on, I think.
Yeah, we're going to have another meeting next week, actually, so a safety meeting.
All right, we will save you a spot right here. Dr. Stites.
Hey, just remember this. We the people are in this together. We the people keep each other safe. And we the people can remember that as the numbers rise, there's still no place like home.
All right, Chiefs training camp. We just switched to some football for just a second.
Any day, any day. There he is, right there.
Time. All right, let's end on an uptick here. Okay, so Chiefs training camp up in St. Joe is just around the corner. Monday, we're going to hear from the team head orthopedic surgeon, our very own Dr. Paul Schreppel. He is we're also going to share this great patient story involving a local student athlete. We're going to share that with you. So enjoy your weekend. We're so glad you joined us today. We'll see you Monday.